Good afternoon to one and all. Today I'll be presenting a rare case series of patients with coexisting keratoconus and pellucid marginal degeneration. What are the treatment possibilities? 10% of pellucid marginal degeneration cases have been reported to be associated with keratoconus, but little is known about the characteristics of these patients. We set out to do exactly that, to study the ophthalmic characteristics and treatment outcome for patients with coexisting PMD and KC. So our diagnostic criteria was as such: a slit lamp biomicroscopy showing presence of two areas of thinning and clinical features suggestive of keratoconus as well as pellucid marginal degeneration. That is a band-shaped peripheral corneal thinning associated with protrusion of the adjacent cornea suggestive of PMD, and a central or paracentral stromal thinning with conical protrusions, scars, fissures, forks suggestive of keratoconus. A Scheimpflug image and an ASOCT was used for documenting these two areas of thinning. Topographic features were studied but not included in our diagnostic criteria. Thus, a retrospective analysis carried out between 2016 to 2022 included 7 eyes of 5 patients with a mean follow-up of 1.6 years. Uh, all the eyes had inferior band of thinning shown on slit lamps, Scheimpflug as well as ASOCT. The mean age was 37 years with a male predominance. Most of the eyes were unilateral presentation, but the contralateral eye of the unilateral cases were diagnosed as keratoconus, and all eyes showed features of keratoconus in the central portion of the cornea. In the interest of time, I'll be showing only 3 cases. This is a 33-year-old female who presented with central corneal thinning, stromal scars, fissures, and Vogt striae, and an inferior corneal thinning. The presence of two thinning areas was documented on Scheimpflug as well as ASOCT. This was a corneal topography which shows an irregular astigmatism on the axial curvature map, with the contralateral eye showing features of a pellucid-like keratoconus or keratoconus. But as the Scheimpflug image shows in the contralateral eye that there was no inferior thinning, so the contralateral eye was diagnosed as keratoconus. She underwent a deep anterior lamellar keratoplasty with a large diameter graft, and at final follow-up, her vision improved from counting finger 2 meters to 6'9". This is another patient, 44-year-old gentleman who presented with a central scar and thinning in the center, along with an inferior thinning in the periphery, which was picked up in both Scheimpflug imaging as well as an anterior segment ASOCT, which shows the intervening area of the cornea as of normal thickness. And this is topographic features of the affected eye showing that irregular astigmatism, whereas the contralateral eye shows features of keratoconus. He underwent a penetrating keratoplasty and developed a steroid-induced cataract 4 years post-procedure, and he underwent cataract surgery for the same, and his final visual acuity improved really well. This is a bilateral presentation where the left eye was more affected than the right eye. One can notice the bilateral thinning in both the in Scheimpflug imaging, and the advanced thinning of 255 microns in ASOCT. She underwent a sclerocorneal intralamellar keratoplasty for the more affected eye, and the central cornea was cross-linked, whereas in the contralateral eye, the other eye, corneal cross-linking was done for a wide area, including the periphery with a limbus protection. So these are our topographic features. But as noted, compared to the other cases, the patient who underwent the sclerocorneal patch graft did not have a great visual outcome and was advised to use contact lenses. So coming to the discussion, keratoconus with pellucid marginal degeneration has been reported way back in 1984 in Japan, where 17 patients with PMD were noted to have keratoconus in the central portion of the cornea. In this large retrospective study done in LV Prasad Eye Institute, 10% of the cases with pellucid have been associated with keratoconus, and they have known to be more seen in males and have a weak association with allergy, unlike keratoconus. And in a national survey of pellucid marginal degeneration done in Japan, the contralateral eye of the pellucid marginal degeneration was studied. The topographic features were more suggestive of keratoconus in such cases. And one, while diagnosing such case, must not rely on topography alone, because topographic patterns can vary, as elicited by the study by Lee et al. And a coexisting PMD can be easily missed if you rely only on topography, and diagnosis is strictly clinical in such cases. So what is in the name really, whether it's pellucid or keratoconus? This is a beautiful article by Bellin et al., which shows a Scheimpflug image differentiating an inferior keratoconus from a pellucid marginal degeneration. How we can differentiate an inferior keratoconus from pellucid is that the superior cornea will be of the superior cornea will be thick, so there will be, you can differentiate it clearly from a keratoglobus as well. And the central portion of a case of pellucid marginal degeneration will not show thinning, and that is how you differentiate it from an inferior keratoconus. So we have these following recommendations that when you're planning a corneal transplantation, in such cases, a corneal transplantation with a large diameter would provide a better visual outcome, and when it would be advisable to crosslink the contralateral eye a little early and including the periphery as well. The limitation of our study is that the pachymetry map provided by the system that we use, that is the Allegro oculizer system, did not provide pachymetry map beyond 9 mm of diameter. Hence, we could not study the peripheral corneal changes. But as we have already elicited in our diagnostic criteria, topography was not a part of our diagnostic criteria, and it was only studied out of interest. So hence, I would like to conclude that PMCD can coexist with keratoconus, and it is vital to include all areas of thinning while planning corneal transplantation. Thank you.
Do you find most of the time the PMD is too close to limbus?
Yes, sir.
So
Yes,
getting
sir.
a full thickness PKs, I think it's not that easy.
Yes, sir. That is, one of the hard part of it.
Yeah.
That's why we planned a large diameter graft to include both the central thinning as well as the peripheral thinning. So most of them, they had, poor visual outcome even, and they had poor contact lens fit also. So we were left with no other choice to improve their visual outcome other than a large diameter graft. Most of them had central corneal scar as well.
So you haven't shown any photograph of the scar or something?
Yes, sir. Presentation is.
It's all right.
Did you try scleral lenses in these patients?
Yes, sir. They had a very poor fit with scleral contact lenses. They were quite advanced cases because that's why the scleral contact lens fitting was very difficult in them. That's why they were posted for transplant.
Why should it be difficult to fit in a scleral contact lens? I can understand a mini scleral, but a proper
The
scleral.
patient was not comfortable with the contact lens fit, sir.
But otherwise, it can be fitted.
Yes, sir. But
some patients are not compliant here. That's
yes,
okay.
and the central scar was not improving the visual outcome with the scleral contact lens.